Thank you for joining our panel discussion on the ethics of frailty. I'm going to be the moderator today. My name is John Muscedere. I'm a professor of medicine at Queen's University in Canada and the scientific director for the Canadian Frailty Network. The discussion today will go on for an hour and a half, as opposed to normally the webinars are an hour, but an hour and a half, since we have four exciting presentations. And what we plan to do is have the go ahead, do the presentations, and then at the end of the presentations, have a question and answer period. We've allotted, the presentations will take approximately 40 minutes, and the end, we've allotted the rest of the time for questions and discussions, since I'm sure the presentations will raise lots of questions for discussions. So the presentations that we have today are on the first one will be on autonomy, dignity, and frailty by Dr. Daryl Pullman. The second one is the use and misuse of frailty by Dr. Søren Holm. Third will be time to benefit in frailty by Dr. Widera. And the last one will be ethics, frailty, and low middle income countries. So I'm going to stop. Stop my sharing, and I'll get Dr. Pullman to put up his slides while I introduce him. Great. So Dr. Pullman is a professor of bioethics in the Faculty of Medicine at Memorial University in Newfoundland. He has broad and diverse research interests and published widely on genetics, ethics, end-of-life care, and ethics in aging. He's been a member of the Canadian Frailty Network for many years and served as many national and international ethics panels. So I'll turn it over to Dr. Pullman.
So the title of my talk is Autonomy, Dignity, and Frailty, Mapping the Ethics Landscape. And I thought it would go ahead with it. So in an editorial written by a couple of the organizers of this meeting earlier this year on the ethics of frailty and need for consensus guidelines, the authors state there is an urgent need for comprehensive consensus-driven guidelines to help the public, clinicians, researchers, policymakers, and other stakeholders navigate the ethical landscape surrounding frailty. But if we're going to navigate the landscape, we have to first map the landscape. So what I want to do in the next few minutes is what I describe as a little bit of exercise in moral geography, as we sort of look at some of the key concepts that make up this landscape for frailty, and discuss them. And as I said, the title of my talk is Autonomy, Dignity, and Frailty, but I'm actually going to take these concepts in reverse order and go with frailty, autonomy, and then dignity. I think actually my title was, yeah, all right. That's all right. So any of us who've been working in the frailty space are very familiar with this Dr. Rockwood's kind of frailty index, and which really focuses on largely the physical capacity of individuals as they move from being very fit until to being severely frail and eventually terminally ill. And but this also indicates that there's a connection between that physical frailty and some of the cognitive frailty that people experience at that time. But frailty, as we know, is more than just physical and mental. There's also emotional frailty. There's financial frailty. There's social frailty, and perhaps other kinds of frailty as well that we'll talk about further today. And so when we start thinking about a comprehensive ethics of frailty, we need to think about all of these different aspects of frailty beyond just the physical and the mental, but other aspects as well, which means that we have to engage with a lot of stakeholders and in sorting out the ethics of frailty. So the other next concept I want to go on to is autonomy. Any of us that have worked in healthcare and have done even a little bit in healthcare ethics are able to recite the 4 principles of autonomy, non-maleficence, beneficence, and justice, which have become kind of the standard approach to medical ethics. But as an author, or as the former editor of the Journal of Medical Ethics once said, he said, ethics needs principles, work can encompass the rest, and respect for autonomy should be first among equals. Because when we talk about ethics and in healthcare, autonomy is generally the one that we focus on most. But in this context, I want to ask, well, what would it mean? How do we think about autonomy as it refers to frailty? And this little graph I put together here, this little chart, indicates that, you know, as far as our practical autonomy is concerned, we at birth we have little to no autonomy, and as we grow and get into our 20s, 30s, 40s, and so forth, we maximize our autonomy. But then as we get older, and as we are talking about here, and frailty kicks in, our ability to act autonomously, of course, fades. And so the question then is, well, the principle of autonomy serves as the de facto practical guide for much contemporary bioethical decision making. Its normative relevance in the context of long-term care is dubious. So my point here is that when we're thinking about autonomy, it's a very important ethics principle. It really doesn't have a lot of staying power in the context of frailty. So we have to look for other concepts, and this is where I'm focusing on the notion of dignity. So the last couple of slides I've got here are just to talk about dignity. I've spent a lot of my the past 30 years thinking about and writing about dignity. And this is an article that I wrote some years ago about the ethics of autonomy and dignity in long-term care. And basically, when we think about dignity, there's 2 fundamentally different conceptions of dignity that are often at play here. The one basic dignity is that intrinsic worth of every human being, and it's a very fundamental moral notion. You don't do anything to gain it, to earn it, and nothing can ever take it away. So if you're a frail human being, you still have this basic dignity, this basic fundamental worth, irrespective of whatever kind of deficits you might have. But when we talk about dignity generally, when we think that, for example, when we say that people have a right to die with dignity, that's a much different conception of dignity that we're talking about there. That's a notion of dignity that can kind of gained or lost. It's contingent. It is more closely tied to individual autonomy, such that if people lose their autonomy, we say they lose their dignity. Kind of dignity here is more akin to an aesthetic notion than a moral notion. So as we think about the ethics of frailty, I'm going to suggest that we have to focus much more on this basic notion of dignity, and that guarantees the fundamental moral worth of every human individual, irrespective of rank or station, wherever they are, and on their frailty journey. So, and just this last slide, I don't have time to go into it, but Dr. Harvey Chochinov, who's a Canadian psychiatrist, has developed a whole area of therapy he calls dignity therapy, and outlines in much more detail some of what he calls dignity conserving repertoire, which I think many of which would apply to the context of frailty. So that's the few slides that I have. Again, I think that part of our challenge is as clinicians and ethicists in sorting through the ethics of frailty is to map the concepts that we're going to use and focus on the ones that will give us most traction in this space. So thank you.
Dr. Holm to put up his slides, and while he's putting up his slides, I will introduce him. So Dr. Holm is a professor of bioethics at the University of Manchester in Great Britain. He holds degrees in medicine, philosophy, religious studies from the University of Copenhagen. He has a broad set of research interests in healthcare ethics and bioethics and the philosophy of medicine. He's been past president of the European Society for Philosophy of Medicine and Healthcare and president of the International Association of Bioethics. I'll turn it over to Dr. Holm.
Thank you. I think, well, when we tried it, there was some problem with showing my slides in full screen mode, but they're not particularly busy apart from one of them. So I think you can see them anyway. So what I'm going to do is to talk about how frailty can be used and misused primarily in decision making. And what we have to think about is that we have frailty concepts at many levels. We have an ordinary language concept. Frailty had an ordinary language meaning before medical professionals and healthcare professionals started using it in a technical way. Then we have a technical concept which we then operationalize, and from the operationalization we make a frailty instrument, an instrument which can measure frailty in some ways, and we can use then that instrument partly for prognostic purposes and partly for use in decision making. And essentially, it will be designed for use in decision making for a particular purpose, and in a particular group. But it may well be used beyond that in actual practice, which I've tried to illustrate with the rather unruly star here. Now, as an ordinary language concept, frail means a lot of different things. Apparently, the first attested use in the English language is 1376, 72. And I've just highlighted this sort of the main meaning, which is the one we are going to talk about today, but it's important to note the fourth meaning, which also exists, and that it could be of a person morally or mentally weak, lacking courage, unable to resist temptation, sinful. This is all from the Oxford English Dictionary. So it's important that these two meanings could come to be conflated. Now, what is it we do when we go from the ordinary language concept to a more technical concept? Well, we define, and here one very much cited example, frailty was defined as a clinical syndrome in which three or more of the following criteria were present: unintentional weight loss, self-reported exhaustion, weakness, grip strength, slow walking speed, and low physical activity. So if we accept this as the technical analysis of frailty, we get a certain group being frail, and we can then estimate for each person in that group exactly how frail they are. Then, of course, there's the other very well-known example, the clinical frailty scale, which again subdivides people in groups of frailty. And for instance, as all scales imply that, let's say, someone in the mildly frail category, that people who are in that category share something. They all share the fact that they are mildly frail, and we then use that in prognostic or other decision making in healthcare. Now, there are a number of uses in decision making. The first is essentially that we could use our frailty scores for advice. We simply support an accurate prognosis and determine relevant treatment or support options from the frailty score, and we use it to advise either the patient or their family. And that in itself doesn't raise many ethical issues as long as the frailty assessment is done using an appropriate instrument. Then another very prominent use is for what we could call positive priority. That the frailty score is taken to indicate a vulnerability to injury that we have to prevent, and therefore we have to do something to help the person who has this. So we're giving them essentially a positive priority that those who are not frail will not be given. Again, this raises no ethical issue in itself, but of course may raise the standard questions of resource allocation. And then thirdly, we could use it to give people who are frail a negative priority. We could, for instance, say, well, those who fall in the very severely frail in the clinical frailty scale, well, treatment of that category of patients is futile, and therefore for certain treatment is futile, and therefore we shouldn't give it. Or we could say we're going to use this to optimize treatment allocation, or to give people who are frail lower priority for scarce resources. And you can see some of this happening in some countries during the COVID-19 pandemic. Now, in relation to futile treatment, there are very well-known issues around defining futility. Now, if something is absolutely futile, i.e. it has 0% chance of working, then of course we shouldn't offer it to patients. But in most cases, when we say something is futile, a treatment is futile, it's not absolutely futile. It has a very small chance of working, and that complicates the use of futility in decision making. And therefore, if based on frailty we say that something is futile, but it's not absolutely futile, we sort of inherit all of these problems. Then, of course, there's a potential for discrimination against those who are identified as frail or falling in a certain category of frailty. And we have a chance of creating a self-fulfilling prophecy in the sense that we say that, for instance, they are at increased risk, and then we might increase that risk of injury by not offering the treatment that we would have offered to people who were not as frail. Then I also want to point out that there is sort of a large penumbra around frailty and frailty scoring. As I said earlier, the instruments that are used to categorize people in frailty categories or assign frailty scores are developed and validated for use in a specific population for a specific purpose. And that means that, first of all, we don't know whether they work in other populations and for other purposes, but also that there can be cases where it's sort of completely obvious that we have a problem. So again, during COVID-19, the clinical frailty scale was suggested to be used not only for elderly patients, but for all patients in certain contexts. And obviously disability activists were rightly up in arms against this, because they said, well, if you use this score, we might be defined as frail because there are all of these activities we can't do, but it's simply a misuse of the score. Now, we can't get around this by simply asking clinicians to consider frailty or assess frailty without using a specific instrument. And the reason we can't get around it is that we have no certainty that different clinicians would do this based on the same conception of frailty. And there is also the risk that they may unconsciously import stereotype. For instance, the stereotype that all elderly people are frail. So I'll stop sharing here. Thank you.
So our third talk, our third speaker is going to be Dr. Widera. If I can ask Dr. Widera to get up his slides. Dr. Widera is a professor of medicine, the School of Medicine Division of Geriatrics at the University of California in San Francisco. He has worked in dissemination to look for dissemination of evidence-based geriatric palliative care. He's been involved both local and in national organizations and advocated for decision making for those who cannot decide themselves. So welcome, Dr. Widera.
Thank you. Can you hear me okay?
Yes.
Can you see my slides?
Yes.
I think this is perfect timing. It's a nice kind of dichotomy between the last talk and this current one. And what I'd like to talk about is prognosticating time to benefit in frailty and really thinking about the concept of time to benefit. See if I can move my slides forward. So I have no financial disclosures. Two things. We do a podcast called geripal.org that we do. And we also have a site called ePrognosis to bring you to prognostic calculators and this concept of time to benefit, which I'll be describing in my talk right now. I'm going to keep it relatively short so we have some good time to discuss some of these issues after all the talks are done. So I'd like everybody just to think for a second, like clinical question. Mrs. A, 75-year-old with AFib, hypertension, COPD, diabetes, osteoporosis, dependence on others for shopping and household chores and bathing. Been hospitalized once for her COPD. How should we think about treatment targets like a hemoglobin A1C for her? How should we think about colon cancer screening? How should we think about statins? Should we continue them? What should we do about blood pressure targets? Should we start a bisphosphonate? All really important, common clinical questions. I think currently you can look up to date or whatever resource that you look at, and you can find the answer to how much will this intervention help. You can pull up number needed to treat for blood pressure. You can pull up absolute risk reduction for osteoporosis fracture prevention. You can pull up relative risk reductions if you're trying to make those numbers look big. But one question that's significantly harder to find is not just how much will it help, but when will it help, which is a critical question when we think about people with frailty. So why is this important? Especially as we think about targeting interventions to those who are going to live long enough to see a benefit. For many preventive interventions, the benefit takes many years to develop, yet the harms become much more immediate. And patients who are frail with a poor prognosis are exposed to all the upfront risks, but are unlikely to survive to see a benefit from interventions that have a delayed onset to benefit. So how do we think about this idea of time to benefit? Again, the time that it takes to see a benefit, and equally, I guess, time to harm. Generally, We want life expectancy to be greater than the time to benefit, where prevention may generally be recommended because it may be beneficial to that person. They're going to live long enough to see that benefit. If life expectancy is significantly less than the time to benefit, prevention is unlikely to help, and we generally don't recommend it. And when life expectancy is about the same as time to benefit, things are unclear. And we should be thinking about kind of patient factors, level of anxiety, willingness to undergo tests, all of those things when we're thinking about, do we recommend or not recommend a particular intervention? So for each one of these, and these are just examples, like what should her hemoglobin A1C target be? How long does it take to see that benefit from tight glucose control versus less tight? How long does it take for someone, for a population of individuals, to see a benefit from colon cancer screening? How long does it take for a statin to be effective for primary prevention? How long does it take for blood pressure? Targeting blood pressure, how long does that take from a primary prevention to actually see a benefit? So our group has done work to try to make this fairly easy to find, or easier than it is in the current literature. So we have a site called ePrognosis. We don't make any money on it. And in the middle button, you can check it out yourself. Just Google ePrognosis, time to benefit. And it comes up with evidence-based interventions and evidence-based time to benefits for particular interventions. So for example, colon cancer screening. It takes about 10 years for you to see a reduction of 1 colorectal cancer death per every 1,000 people screened. Mammography also takes about 10 years. When you're looking at bisphosphonates, maybe closer to 1.5 to 2 years to start seeing that benefit. Intensive glucose control, again, about 10 years to prevent microvascular complications in individuals. Blood pressure control, about 2 years to start seeing it for primary prevention. Statins, about 2.5 years to 3 years. And other things too, and this is important as we think about treating people who have limited life expectancy, so you can even think about antidepressants. Again, we have a number needed to treat. How much will it help? We know on average, the number needed to treat for an antidepressant for treating depression is about 6. So you have to treat 6 people to see 1 person benefit. The other question is, how long does it take? And we know it takes on the order of about 6 to 12 weeks to start seeing a benefit. And in the work that I do also in hospice, that's a really important marker as I think about how best I should treat somebody for a depressed mood. Are they going to live long enough to see that benefit from that antidepressant? Or should I be thinking about something else? So that's the whole idea when we're thinking about time to benefit. Happy to talk more and talk as a group to talk about kind of how we even think about prognosticating in older adults, especially after that last talk. And I'll turn it over.
Great. Thank you very much. So our last talk is going to be by Dr. Geffen. Dr. Geffen is a GP based in Cape Town, South Africa. He's the director of the Sampson Institute for Aging Research and a senior lecturer in the Institute of Aging in Africa at the University of Cape Town. He's done an extensive amount of work with the World Health organizations, Clinical Consortium for Healthy Aging, and he's was recognized by the WHO on the World Report on Aging as a recognized expert in this area. So welcome to Dr. Geffen. Geffen.
Thank you very much. Thanks very much for the invitation, and welcome from South Africa. So I think we're all very familiar with the autonomy, beneficence, non-maleficence. Most ethics talks I've ever been to as a family physician focus a lot on those aspects, seldom look at the elements of justice. And I just thought what I'd like to do is to take a perspective of frailty and look at it through a lens of justice. Erica, I didn't mean to steal your case study, but this is Mrs. M, who's 64 years old. She lives in an economically deprived neighborhood about 25, 30 kilometers from the CBD in Cape Town. She's with her 74 years of husband. She's also got hypertension and type 2 diabetes and osteoarthritis. She's had heart failure and been admitted to hospital. She's had a stroke. And she lives in a slum. For all of you who've been to visit in Cape Town, I think a beautiful city, but we have quite extensive slums. And one just needs to consider what life is like for Mrs. M, who lives in an area like this, and without having to do either a Rockwood score, or whether we look at the freed elements that make up frailty, she would probably be categorized as frail. We know that in the world, in 2000, we had about just under 500 million people who were over the age of 60. And by the year 2050, we're going to have about 2 billion people over the age of 60. We always thought that growing old was a high-income issue, related to high-income countries. But the biggest growth is going to be in low and middle-income countries, in older persons. And we're going to see about 1.6 billion people living in low and middle-income countries by the year 2050. And if we look at what the in 2015, if we look at the number of people living in countries where there are 30% or more of the people aged 60 plus, it's only really been in Japan. But if we project forward to the next 25 years, we're going to be seeing more than 30% of the people in countries like Canada, certainly in China, most of Europe, and Africa, where you had less than 10% of people aged 60 or older. In 2015, we're going to see many countries in sub-Saharan Africa starting to go into where 10 to 30% of your population is going to be over the age of 60. But very tellingly, we're going to see a 4 times growth from 47.7 million people in 2015 to over 187 million people by 2050, age 60 plus in sub-Saharan Africa. When we look at life expectancy at 60, we know that it's all well and good to live long lives, but we would like to live good lives. And what we can see is the vast difference in life expectancy, and not only life expectancy, but healthy life expectancy at the age of 60. In Europe, North America, around about 17 years. In Africa, it's sitting at about 12.8 years. So a 60-year-old today in Africa would expect to live 12.8 relatively good years, and then an additional 4 years living with disability. And if we're going to use living with disability, we can use it as possibly as a proxy for frailty. It's people living with chronic conditions, people living with significant morbidity. So a significant difference in life expectancy at age 60 between Africa and the Americas and Europe. And what really is, I think, important around justice is talking about access to services, long waiting times. How do you get into your clinic if you don't have any transport? How do you overcome the geographic limitations often that we find in Africa, where you've got poor road networks, where people have to travel very long distances between clinics because there are a lack of clinics. There's a significant number of institutional barriers denying services due to age. There's a strong focus on child and maternal health in sub-Saharan Africa, on combating infectious diseases such as HIV and TB. There's trying to deal with non-communicable diseases. And in many countries, when you look at their health policies, where you ask, where does aging fit in terms of a national framework for health policy? Well, they turn around and say, well, either we don't have one, or alternatively, it fits in under the ambit of non-communicable diseases. And there's often a priority given to younger people. So older people may arrive at a clinic, be last in the queue, and they'll not be able to be seen because younger people have pushed in front of them, or will be able to elbow their way to the front. We also know that despite the need for healthcare, Africa as a continent has the highest burden of disease, but the fewest number of doctors and healthcare personnel, as we can see here. We know that as a family, my interest in being a GP and a family doctor is at a primary care level and how we work in primary care and mostly in a preventative state. But if we look at the consultation time that it takes or available to a patient with a doctor in many countries, and the time ranges from 58 seconds in Bangladesh to about 22 minutes in Sweden. And 18 countries representing more than 50% of the world population, you've got less than 5 minutes with your primary care practitioner. So if we're going to start talking about assessing frailty, I can't assess a person, I can't do a freed frailty score on someone in less than, it probably takes 3 minutes, I imagine. You've got to get them to stand up and down from their chair in 30 seconds. You've got to make them do a timed up and go test and do a, I don't have vast numbers of doctors or nurses don't even have dynamometers. So how do we measure for grip strength, etc.? So practically, it's almost impossible to do assessments for frailty. And when you're doing 90 consultations a day in countries like Bangladesh and China and Pakistan and many, many areas of South Africa in public health service, 60, 70 patients a day, there's absolutely no way you can devote the time that you require, that is required by patients for this. When we start talking about discrimination, us as doctors and healthcare professionals are very good at overlooking and downplaying symptoms. People come to us and say, oh, I've got a sore knee. Well, you know, you're old. What do you expect? My memory's failing. Well, everyone who gets to your age has poor memory. We know that there's inadequate management of health conditions due to clinical bias. Someone who's in atrial fibrillation will maybe be denied some sort of anticoagulant because, well, we're not sure it may help. You may have a fall, and if you fall, you may bleed, etc. And there's a significant lack of geriatric training. In virtually no medical school in Africa is there any substantive part of the undergraduate curriculum in geriatrics. In South Africa, we have less than 20 geriatricians for the whole population of over 60 million people, of whom about 8 million people are over the age of 60. So a massive under-resource. And countries like Uganda, I think they have 1 geriatrician for the whole country. We know that people from studies that we've done in Cape Town, that people who go into the primary healthcare clinics feel that they're not cared for. There's a poor perception of quality of care. Thankfully in Cape Town, which is, we've got 2 medical schools, a dental school, a relatively high income relative to the rest of the country, a relatively well-established primary healthcare network. People say they can access the care, but when they get there, there's a poor perception of quality of care. They say that the health professionals lack any understanding of their care needs, they don't spend any time with them, they don't have the skills, and they often have great difficulty with communicating in terms of language barrier, and people are lacking trust in the healthcare system. And often care that people are receiving is very process driven. I've gone in to the clinic and all they did was take my blood pressure. No one asked me, how am I feeling? No one asked me, am I feeling down? Am I sleeping well? Am I lonely? Do I have pain? And am I incontinent? Allocation of resources is a very, very significant part of meeting the needs of populations. And it's frightening to know that low and middle income countries have over $29 trillion of debt. And this was reported in the New York Times, and it's relatively well known in June this year. And if you read the tag, or just below the headline, it says a few decades long crisis is getting worse, and now dozens of nations are spending more on interest payments, not capital repayment, just the interest on healthcare or education. And that's a damning indictment of what's expected in terms of countries who have to be able to provide healthcare to their people, but instead they've got to repay debt, often systemic corruption that's existed, poor management from organizations like the World Bank, the IMF, loans that have made it usurious interest rates, and debt is climbing merely because countries can't service their interest. So if we consider the WHO's public health framework for healthy aging, where one wants to maintain function for as long as possible at a high and stable capacity, but recognizing when we start becoming frail, our functional ability is going to decline. And that is related to what the new WHO concept called intrinsic capacity. It's our physiological well-being and our cognition, etc. As that starts declining, so does our functional ability. But all of those elements are underpinned by major areas made up of our health services that we have, the long-term care that's provided in terms of who's going to provide the care services to older persons or people as their functional ability starts to decline, and the environment in which they live. And the environment is key to a healthy and good life that people should have, because we know that there are so many social determinants, environmental determinants of disease, which when you're living in a poor or in a marginalized community, underserved, under-resourced community, even in high-income countries, your health outcome is going to be much, much worse than that of a healthy, robust older person living in a relatively high income. We saw that what happened in COVID, that the most marginalized people within communities in high-income countries had the worst outcomes. So it's not just a low and middle income country, it's often an under-resourced and underserved area issue that causes major problems. So if we think about the issues relating to Mrs. M, who's living in a slum, questions that she's interested in asking: I'm having difficulty caring for myself. Who's going to care for me? Can I afford any care if I don't have my husband's 74 years old, my daughters have to work, my grandchildren go to school. Who's going to be able to care for me if I don't have anyone at home? And if I do need some sort of care, I need to be admitted to hospital, or I have some major health condition, will I be denied care merely because I'm older? So that in a nutshell is just a sort of a macro view or an overview of what I believe are key elements of justice that make up the component of frailty in terms of the ethics to deal with older persons, and I think may be worthy for some discussion in a moment or two. So thank you very much.
So thank you, Leon, and thank you to all the presenters for their presentations. And we're right on time. So we've allotted a lot of time for discussions. I'm going to ask everybody to put questions in the chat so that we can address them. I'm going to moderate the chat and try to group questions as they come up. But so thank you. Maybe actually I can start off to all the panelists. Hearing each other's presentations, did anything strike you, or is there opportunity for standardization of how we approach ethics in older individuals and people who are frail, or maybe is that a hopeless cause, and maybe we need to tailor it to different circumstances, different countries, different medical systems? So I'll open it up to the panel, and then we can get into the questions on the chat. Søren, you're muted.
Yes, I am. Sorry. I think it depends on what you mean by standardize, in the sense that obviously the options that are available in a well-funded healthcare system will be different from those that are available in a healthcare system that's not well-funded. So if we can't standardize, let's say, treatment advice and sort of in a very fine-grained way, that will have to be healthcare system by healthcare system. But I think we can standardize the way we should then think about sort of how we develop that advice and what the ethical principles that should underlie that is. And I'm much more hopeful for that.
Leon, any comments about that? Sure.
Yeah, I think that this, context is really important. But I think the basic underlying principles, as have been alluded to, and I think the issues of dignity, autonomy, beneficence, non-maleficence, if we don't adhere to those basic principles, no matter what service we have available or what treatment options we have available, it is about being person-centered and taking cognizance of this person that is in front of us as a patient, as a human being, and acknowledging and hearing them. And too often, I think in healthcare, we try and skirt around issues. I don't ask questions I get when I speak to my colleagues. We don't ask about cognitive impairment because we have no way of dealing with it. We don't ask whether people are seeing well because we don't have a cataract service. So if I do identify someone with, no, on the contrary, we do need to ask it. We do need to engage with our patients because it's what they're experiencing. And I think that's part of the difference in terms of how context plays a role.
And I'd also add that, being in the US, we spend double on healthcare as far as GDP than any other country on the planet. So one could argue that we're well resourced, but for people who are frail, for people who are dealing with multimorbidity, we will pay for $50,000 drugs per year, $200,000 drugs per year, but we won't pay for caregiver support at home. We won't pay for the things that make kind of daily life for caregivers and their family members and the patient themselves be not institutionalized, being a place that they want to be. So I think even in a relatively well-resourced healthcare system, we are very poorly resourced, I think, for some of the things that matter most for patients and their caregivers and family members.
Okay, maybe we can move on to the to some of the questions in the chat. So the first one that has come up is for Eric, and it looks at so the question is, do you think we should consider stopping medications for diabetes, high blood pressure, stop screening for cancer for people over the age of 75, or maybe broader? How do we think about deprescribing or medication optimizations in people who are frailty, since we know that polypharmacy is an important determinant of outcome?
Yeah, so great question. So if you just look at age itself, should age 70 greater than 75? So Zeke Emanuel, I think, wrote an ethicist out of Chicago, wrote a paper that after age 75, he would not pursue life-prolonging therapies. So people use age as this de facto prognostic tool where maybe we should stop treatments after that particular age. But the biggest problem is when you think about prognosis, a single factor like age rarely gives us enough information to determine prognosis. So if you look on average, how long does a 75-year-old female in the United States have to live? It's about 12 to 13 years. So just on average in the US, yes, they should get a colonoscopy. Yes, they should get a mammogram. Yes, we should be doing more intensive diabetic control on those patients because on average, they're going to live longer than time to benefit for those treatments, which is about 9 to 10 years. The issue is that when you break down age, you can have in the top 10th percentile people who are living over 20 years and people in the bottom 10th percentile who are living about 2 to 3 years. In that 75-year-old group. So then you have to think about, okay, how do I determine who's in the top and who's in the bottom? And then things get kind of complicated. I do think this is where the role of prognostic indices come in play. I think this is the role of clinician judgment in thinking about prognosis. There probably is an upper age range. It's not 75 when we think about some of these things like colonoscopy screening. But I think the key is that older adults are pretty heterogeneous as far as prognosis. And using a single determinant like age is not helpful. Combining other things, potentially cognition, frailty, multimorbidity together, gives us a much better picture as far as will this patient benefit from a particular intervention.
Thank you. Leon.
Eric, so I'd like to challenge you. Your 75-year-old patient with a multimorbidity comes into your rooms and you say, well, my dear patient, you've got all these complications. You're prognosticated that you've got about 6 years to live. And she says, I've got tummy pain. And my friend down the road, she had a colonoscopy. And, she had the colonoscopy. They gave her some sedation. She was home the same day. And she was actually right the way she was the following day. I want a colonoscopy. You say, it's really not going to benefit you. And she says, no, doctor, I want a colonoscopy. You say, I really don't think we're going to do it. And somewhere or other, it's going to be a battle of wills. At what point does her right to make a decision about her healthcare trump your right to deny her that?
Yeah, great question. I mean, I think a couple of things to consider is A, are we thinking about the same thing? Is this a screening colonoscopy, or is this a diagnostic colonoscopy for somebody who's having symptoms that we're concerned about? And remember that the goal of a screening colonoscopy is not to find cancer, it's to find a polyp that will develop a cancer sometime in the distant future, about a decade from now. And people often think, oh, if I don't get a colonoscopy, I'm going to get colon cancer, right? So again, that's what we advertise too, like get your colonoscopy or else you're going to die from colon cancer, which in truth, the number needed to treat for a colonoscopy at 10 years is 1,000. You got to do 1,000 colonoscopies, not to prevent one death, but prevent one colorectal cancer death. So I think part of this is just messaging that we do. I think that the other thing for this individual is I probably wouldn't start off by saying you're not going to live long enough to benefit from this test. We actually have a study, Nancy Schoenberg out of Harvard did a beautiful study of how people wanted to talk about this. And it was not, you're not going to live long enough to benefit from this. It was about shifting priorities to other things that are important to them. That's how they want to talk about maybe lightening up their blood pressure meds, maybe not pursuing these colonoscopy screening. I do think hearing from them and hearing about their anxiety over this matters because that shifts how we think about whether or not we should do this test. And ultimately, there are people like, if you have somebody in your hospice unit, I'm not going to get you the colonoscopy, a screening colonoscopy, because it is not going to benefit you. So I think setting some ground rules is important. But it's all about communication at this point and using that right framing. Because ultimately, we are all decisional architects. The way we present decisions influences how people make decisions. And I would argue, Leon, if I use that terminology, sure, we're going to have this big fight.
Daryl or Søren, any comments on the previous discussion?
Well, very, very interesting. I mean, we deal with that general problem of patients demanding certain things. I had a physician I worked with a while ago. She said she decided to quit doing ultrasounds for uncomplicated pregnancies. She just decided it wasn't, it's become part of normal care that you come in and get an ultrasound at X number of weeks and so forth. And she said just virtually never find anything as a problem. It just became part of the culture of doing this thing. So she decided she just wasn't going to order them anymore. And her patients started saying they were going to go to Dr. So-and-so because she's a good doctor. She does ultrasounds, So in our resource-rich kind of environment, we treat healthcare largely as a commodity that you can buy and so forth. But I do think that we should be thinking about changing our thinking in those regards. And that this is a service that's provided for you. It's not something that you can dictate. Of course, it's become worse and worse with Dr. Google and so forth. Patients come in now on a regular basis. I have my clinician friends telling me they come in, they've already diagnosed what their problem is. They have to come to the doctor because he or she can give them the prescription or order whatever it is they've decided they need already. So it's again, it's much more a rich world problem, I suppose, than what you're experiencing in your space, Leon. But yeah, these are wicked problems. It's hard to resolve them.
But yeah, I think one of the issues is also that it's not made clear to people what the risks are of having a positive screening result, whatever the screening is. That's, you run a huge risk of finding yourself on a pathway which will lead to overdiagnosis or potentially negative side effects. And I think sort of as long as people don't fully understand that, it's not odd that they want more interventions, because what they see are the upsides, not necessarily the downsides. Of course, if the case had been in the UK, we sort of, the patient would just be told, well, if you want this colonoscopy, there's a very nice private hospital down the road, and they will happily do it for you tomorrow. You just have to pay for it. You're not getting it on the NHS.
Interesting, interesting discussion, especially as we go on into extremes of age, where I think there's both problems. There's age is considered a number without considering the functional or comorbidities, or in both ways, and sometimes we've oversold the ability for therapeutics. For example, you need to be on a statin when you're in your 90s and you're 95, and then the benefit to that, because deprescribing and polypharmacy has significant downsides to it. So the optimization of medications is so important in this population, or procedures, or anything else. And we see this in the intensification of care towards the end of life, and we don't take into account or the demand is that we continue to do everything and not consider what stage of life people are in. But switching the discussion.
Can I just add one other thing?
Yeah.
I'd also say is that there are some interventions where we think the older you are, the more benefit you're going to get from it. The more multimorbidity, the more frail you are, the more you're going to benefit from it. I think a really good example is a COVID vaccine. Is looking at the data, I does not look very promising for like an 18-year-old as far as seeing a huge benefit from a COVID vaccine versus an 85-year-old with multimorbidity. Where the benefit, including from a societal standpoint, is much greater. In the US, everybody over the age of 6 can get their yearly COVID shot. In the UK, right, it's limited to those people who are going to benefit the most. So if you're 18, maybe you can find somebody to give it to you if you pay, but NHS is not going to pay for it. So I think, as we think about how different societies kind of weigh these things, it's not always that just because you're frailer, you're less likely to get something.
Thank you. Yeah, no, that's a very good point. And bringing up the COVID, maybe I can get a comment from the panel as to how COVID changed our approach to to frailty, or certainly brought frailty to the forefront as maybe a way to limit the receipt of life support, or trying to identify who would or would not benefit from life support. So maybe get a comment from the panelists as to how the COVID pandemic changed our approach to ethics and how we approach people who are frail or who are later in later stages of life.
So I can speak a little bit from my perspective, and having worked at primary care level in care facilities in the UK. I think in the US you call them long-term care facilities. In the US, in the UK, called nursing homes, etc. I think at the outset of the COVID pandemic in South Africa, and as we saw the impact it was having on older people around the world, particularly in Italy, there was this massive fear. And suddenly everyone said, well, we've got to start looking at how we're going to protect older people. And there was a sense amongst those of us who are working in the field of aging and older persons that, my goodness, this has been the most neglected group of people up to now in the healthcare service. Maybe by the end of the COVID pandemic, people will be attuned and knowledgeable and understanding the needs of older persons. And there was this great hope that we're going to go into this healthcare system very unprepared, but we're going to come out with a far better and more robust system, particularly that's going to focus on the needs of older persons. But I'm really sad to say that 2 years down the line, or it is about 2022, I think, when we probably had our, or end of 2021, when we had our last sort of lockdown, things have just gone back to normal. Older persons' needs in South Africa and sub-Saharan Africa just receded back into the background. No longer a major necessity, no longer a major need. So that's very sad to see, and the impact of COVID has not really had any lasting, I don't believe, or meaningful effect on the care of older persons.
I think one thing that happened early on, at least in some countries, including some places in the UK, was that people initially said, well, we're going to use age in relation to the allocation of intensive care spaces. And then they realized, well, that is illegal because it's incompatible with equality legislation across Europe. And at least one of the reasons that people found frailty attractive, I think, was that they saw it as a sort of potential substitute or for age. Well, we can't do age because it's illegal, so let's find something else which does the same job, and sort of broadly points out the same group of people. So let's start frailty scoring. And that, of course, then creates some of the problems that I mentioned, because sort of the frailty scale that was then used, the clinical frailty scale, is simply not designed for that particular task and not validated for that particular task. So it creates all sorts of problems.
And that brings up the other question is, how do we handle the tension between people who have advanced stages of frailty, whichever way that you measure it, and the demand for healthcare resources, or the pressure on the other aspect of it is to not to limit the use or reduce utilization of healthcare resources to people who may not benefit from them. And at one point, and what are the cutoffs, or how do we establish those, and how do we move that area forward? We're probably going to have new pandemics. We're probably going to have, there's going to be increasing resource limitations, and resource limitations are common in all our environments in different settings. So how do we handle that tension?
So I want to, once again, coming from a Sorry, Søren, am I riding over you? I'm not sure if I'm speaking of you. Coming from a low middle income sub-Saharan Africa, the areas that do the worst in any pandemic, in any major global crisis, with climate change, are poor people and old people. The resilience, I think societal resilience, frailty, all much the same. And poor countries do the worst. They have fewer resources. There's easier and quicker spread of diseases. And I really do believe that response to global pandemics, global health crises, have to be tackled at a global level and have to acknowledge the impact that all the impact that what's happening in high-income countries in terms of climate change, in terms of consumption of resources, in terms of draining of human capital from low and middle-income countries, because we are seeing the drain of human capital, the lack of funding for research, the lack of funding for training, etc., has to be redressed. And I think it is that's one of the reasons why I'd like to bring the issue of justice to this whole discussion, in terms of in not entrenching the inequality that exists at a global level.
Any other comments on that?
Yeah, I think the one thing we probably have to insist on is that sort of that any use of frailty scoring for decision-making purposes should be evidence-based, in the sense that we need to know that for the particular condition treatment pair that we are making a decision about, that the frailty scoring system that we're using actually predicts in the way we think it does. And that, of course, it's just it's a question of generating the evidence in various ways. But I think that there is a risk that sort of, if you have a frailty scoring system that you are acquainted with and use, you think that it predicts or that it informs many more decisions than it may actually do.
I appreciate your interest in justice, and clearly there are tremendous injustices in this space, and you've enumerated a number of them in the developing world. I have to, speaking personally, I'm just overwhelmed by that. I'm like, what would we do to start to address that? It is so deeply entrenched in the way our world has, since the Industrial Revolution, has sort of evolved into this space. If you had working in that environment where you are, I mean, we see it in Canada all the time. We're bringing nurses in from all over the developing world. We're bringing medical trainees in because we need them. We need them. We can't. We don't have enough trained here ourselves. If you said, well, from my perspective, here's one thing I think that the low-hanging fruit in this space that we have to do that we're just not doing, what would you say that would, to begin to, it's never going to be just, but we're going to start to address that?
The easiest thing, but the most difficult thing to do, and the simplest thing, would be to cancel debt or reduce the debt repayments that countries have to make, and allow them to focus it on health and education and retaining a workforce and building skills. To ask a country like Kenya to pay probably close to 60-70% of its GDP away in debt is disgraceful. And the people who are suffering from it are people who had nothing to do with the decisions that were made that's affecting and impacting their lives. And whether it's, you know, pointing fingers and saying, well, you're a corrupt government that preceded you, or you did this, or your government did that. It's the people on the ground who are suffering. It's not the you know, massive financial institutions who are going to suffer an enormous meltdown if they had to give some major debt relief to poor countries. So I think debt relief is the one big thing. Second thing is, if we start looking at vaccines in South Africa were incredibly expensive because they were being paid for in dollars. Now, they were probably costing pennies to produce. So there's issues around trade agreements and access to less expensive drugs, which are protected through you know, through patents, etc. So it's about looking at how one deals with those sort of issues, and certainly vaccines should be made universally available. COVID didn't ask if you picked up your illness in Wuhan province in China, and because you traveled from Wuhan to America, you suddenly transmitted the virus. Make the stuff available and allow it to be used at a global level. So we do need to have some sort of global response to these sort of pandemics. So yeah, cancel the debt or reduce the debt significantly, but that's maybe never going to be achievable.
I guess one question, just to push back, like when we think about even the concept of making a vaccine universally available, yeah, I think when it comes down to the specifics, what does that actually mean? Because ultimately, we are in a resource-limited world. We will always be. Do you make it available for those patients who are just most likely to benefit from the vaccine globally? Do you make it freely available to everybody and encourage everybody to do it like the US does? Do you do it like the UK does, to focus on specific segments that are going to be most likely to be available? So even if there was a mechanism to pay for it in lower income countries, I think we still have to think about this justice issue of who benefit, even if it's cheap, who still benefits, and where does that cost becomes, even if it's cheap, too much for so little benefit. And that's what we struggle, not just with these vaccines. I mean, there's an active debate in the US on Alzheimer's treatments because we're seeing marginal potential benefits, significant harms. How much money do we put into something like this when the benefits are so small? In the US, we pay for it. I think in the UK, you decided not to pay for it. Thoughts on that, Leon?
Yeah, I think there's a big difference between giving someone one of the latest biological treatments or immunotherapies to try and reverse Alzheimer's disease or prevent it progressing, to getting out thousands or millions of vaccines that are quick to administer and jab into people's arms. We've seen the global impact that preventing things like measles has had on the world's population. And coming back to the issue around, you know, should we vaccinate children? I was running large vaccination programs during COVID. I mean, we had nothing else to do as GPs other than our practice were effectively shut down. No patients came to see us. So what did? We gave COVID vaccines. And I had the belief that you should just put a COVID clinic on every corner. And as a person walked past, just sort of jab them in the arm, you know, a little bit like throwing darts at a dartboard, you know, grab them in the arm. And I'm joking, obviously. But the reality is, if we vaccinated kids who came into the household where you've got 8 to 10 people living in a household, where you've got 10 to 12-year-olds who've gone to school and where they're living with their 70 or 80-year-old grandparents, you want to stop them bringing the COVID into the home. So it makes sense in the midst of an epidemic or a pandemic that you want to vaccinate as many people. Just get the jabs in. In terms of future prevention, well, you want to prevent harm, and there's no pandemic at the moment, so let's vaccinate older people. So it is horses for courses. It's about being pragmatic. But the one thing that shouldn't happen is to say, I'm terribly sorry, you can't get it because we can't afford it. I think there's a significant injustice in that.
Great discussion. So there's a couple of questions in the chat. The first one pertains to how we actually engage families in the discussions, or how do we get to know families and patients to discuss this? Because one of with everybody being so busy, and I saw some of the average time that a physician spends, or a clinical practitioner spends with patient is very little. So how can we actually facilitate some of these discussions that can be complex, can take a long period of time with families and patients?
Yeah, directed at me, John?
Directed at anybody. It's such a simple question.
Yeah, it is. I think we've overcomplicated healthcare. I think that so much of the stuff that we as doctors do is about thinking, but what we should be doing, what we're really good at, is thinking and putting together complex problems and sort of helping people come to some sort of conclusion about things, much as Eric mentioned earlier, in terms of his patient, or the patient who is demanding a treatment. We ask a lot of questions, and it takes a lot of time. So when we look at the process of what we do as doctors or healthcare professionals, is there something that can be done possibly better, possibly the same, and give us the information that we need that doesn't expend an enormous amount of our time? And not to say that we don't have the discussion with patients. That's not what I'm saying. But I'm saying there's a lot of stuff that we do in healthcare that we possibly could be devolving to other people. And I think about what's happening in Africa in terms of community health workers, the impact that they're having. We've certainly seen in studies that we've done in peer support programs for older persons, the impact that those peer support programs have on reduction in loneliness, improvement in mood, sort of a non-significant reduction in falls, but nevertheless a benefit. Benefit to both the peer supporter and to the healthcare recipient. The healthcare professional feeling more empowered because they've got more time to spend with the patient. Someone who acts as a healthcare advocate, and the positive outcomes. So we've seen that, for instance, in prevention of mother-to-child transmission of HIV. So there are plenty of models using the so-called less expensive, less trained individual, not us who've spent maybe 12 or 15 years at medical school and postgraduate training and become highly expert in subspecialties, but using our expertise to actually engage with the patient and ask, what is it that you really need now that we've got you, now that we understand what your problems are? That's just my feeling. And I think that's the way, ultimately, if we're going to have to provide just a simple calculation, if we've got 220 million older persons living in Canada, USA, and Europe, and each one of them, according to the WHO, should have an annual comprehensive geriatric assessment. Now, in my practice, it takes me about an hour and a half to do a CGA. By the time I finish speaking to the patient, worked up the treatment plan, whatever, an hour and a half. That's 300 million hours. Okay, maybe you guys are much more skilled at it and you can do it in an hour or 45 minutes. But you're going to need 200 million hours of doctor time. Where are you going to ever find that to do the CGA? So we have to use community health workers. We need to use lay health assessors, etc.
I'm rather pessimistic how things are going in the US right now. It's nearly impossible to find a primary care doctor. I myself had to switch to the service called One Medical, owned by Amazon, where I see random nurse practitioners and maybe a doctor to deal with acute issues if they come up, but nobody that I know, nobody that I trust. And it's very transactional. And I worry that that is where we're going with medicine. And it's a terrible system for people with multimorbidity. It's a terrible system for frailty because there's no quarterback. There's nobody kind of helping steer this ship and thinking about it. So you may have a lot of specialists, but nobody thinking about the whole person. And I think this is a struggle. Like when we think about how do we build trust when we have only 10 minutes to see a patient, you don't. Like, how do I have a good relationship with my son if I only see them once a year? You don't. We've created this system that's set up for failure. And then we wonder, we put all this weight on our shoulders. Why? Why are they not listening to me? Because the system is perfectly designed for the results it gets. There are some things that we can still do. So in my work in palliative care, evidence-based palliative care is the very first thing is we talk rapport building and relationship building is key. Building up that trust, figuring out how they're coping with their illnesses is important. More important than are you taking that medicine potentially is how are you dealing? Even with somebody who's just diagnosed with blood pressure, how is this sitting with you? That's a big thing for somebody who's otherwise been healthy, and now you're giving them a disease label, even that. So and that doesn't take a whole lot of time, and you can build that trust over a while. With that said, I'm pessimistic that we're going into a system where we're just not going to have stable relationships with patients.
Søren, anything to add to that?
No, I think the only reason that it might not come to the UK anytime soon is that no one has found a way to make the business model work yet. But there are plenty of firms that are trying.
The biggest problem in healthcare that we see it as a business. We spoke about commodification. Everything's got a value in terms of a commodity value, and obviously it's got to be paid for. But maybe we need to reframe how we start thinking about the provision of services and care, and that there shouldn't have to be a monetary value placed on everything. I mean, I don't know. I think somehow or other we've really have lost our way in all of this.
And just to follow up on that, the system as it currently, and the comment in the chat is that we have a reactive rather than a proactive system, especially in as people age. So how do we actually think about changing it from the reactive to a proactive, where we can actually try to anticipate some of these things, or can we advocate for that, or is there any hope of doing that?
Well, I think one of the challenges in Canada, John, as you know, is that what's the billing code for that? You know, it goes back to Leon's point. You know, like if you're going to have physicians are fee for service, and they're going to be proactive, they have to be able to bill for it. And maybe we have to stop fee for service and put physicians on salaries.
I think a lot of medicine, certainly in South Africa, we've got this blend of fee for service and a public health sector. You don't get rewarded for thinking, you get rewarded for doing. So putting a scope into someone's orifice is going to give you a hell of a lot more money. And truth be told, a gastroenterologist can do a scope, an upper GI scope every 10 minutes. And if he's running or she's running 2 theatres, it's merely walking between one and the other. You can be doing 6 to 12 of those in an hour, and probably billing on an annual basis, probably 20 to 30 to 40 times that what I'm billing when I'm spending an hour with a patient trying to understand why they're falling and why they're incontinent.
Yes, that is so true, that that activity is rewarded more than thinking in a lot of things. And with an older population, older populations in most of the health systems in the world, maybe there's opportunity to advocate for different approaches as we go forward. We're reaching the end of allocated time, so maybe what I'll do is just go in turn and see if there's any final comments. Maybe I'll start with in the order. Maybe we'll do it in the order of the presentation. So I'll start with Daryl.
Oh, nothing else to add. It was very enjoyable. Learned a lot just listening in. Thank you.
Great. And Søren.
Well, I just want to point out that there was something very interesting in Daryl's talk about the relation between frailty, autonomy, and dignity, which would be very interesting to explore in more depth.
It's hard to do that in 10 minutes.
Yes.
And
I think
Daryl.
yeah, my turn. I mean, I think I love this idea of learning from each other across the globe, because I certainly, to be honest, I've been depressed in the last week with some developments in the U.S. that you may or may not heard about. And I think it is actually helpful to hear kind of how things are going, the struggles, the overcoming the challenges that different people are doing around this topic. So I find these panels actually motivating. And for Leon too, I think one question that keeps on coming to mind is what can I do potentially as a single provider when it comes to some of these issues around global justice? Because that feels overwhelming. Like I am not going to solve debt issues in my daily practice.
So, Eric, we can have an offline chat about it and have a virtual coffee over a discussion on that one. But similarly, just think about what does it feel like for the doctor who opens the door of their consulting room and looks out into the clinic and waiting room and sees 40 patients waiting there and thinking, how the heck am I going to get through that this morning? So I've spoken a lot, but this has been really wonderful. Thank you very much, Sean and Jorge, for inviting me. So I really appreciate it. Thank you very much.
Well, and thank you. So I'd like to thank all the panelists for the discussion. I'd like to thank all the participants for to tune in the webinar for your questions. Sorry about some of the technical issues earlier on, but thank you again. The next webinar will be on December 11th, 2024, and that's on fading appetite, fading function, appetite loss as a clinical marker of loss of function and frailty by Philippe Barreto from Toulouse. So hopefully you'll join us for that webinar in December, and thank you again for participating today. And with that, we'll bring the webinar to a close.